Welcome to our presentation on neonatal resuscitation and delivery room stabilization. This session covers high-yield concepts that are frequently tested on the neonatal nursing certification exam. We'll go through the critical aspects of neonatal transition, assessment techniques, and interventions that every neonatal nurse should master. In this presentation, we'll cover several key objectives. First, we'll explore the physiological transition to extrauterine life. Understanding this foundation helps us make better clinical decisions. Next, we'll master initial assessment techniques, which are crucial in those first moments after birth. We'll then focus on implementing effective ventilation strategies, which is honestly the most important intervention in neonatal resuscitation. We'll also cover appropriate interventions for critical situations and finish with post-resuscitation care essentials. By the end of this presentation, you'll have a solid grasp of these concepts for your exam and clinical practice. Let's start with the basics. About 10% of newborns need some assistance to transition successfully. That's 1 in 10 babies. The single most important intervention in neonatal resuscitation is effective ventilation. Remember this point. It shows up repeatedly on exams. Heart rate and respiratory effort are your primary indicators for decision-making. Clear communication and teamwork are absolutely essential for successful resuscitation. And lastly, your knowledge of transitional physiology will guide your interventions. Understanding the why behind what you're doing makes a huge difference. Preparation is critical for successful resuscitation. Pre-warm the room to at least 26 degrees Celsius or 78.8 degrees Fahrenheit to prevent hypothermia. Always test your equipment before delivery. There's nothing worse than discovering your equipment doesn't work or isn't available when you need it. You should anticipate needs based on risk factors. For example, knowing mom has diabetes or there's meconium-stained fluid helps you prepare. Assign specific team roles in advance. Decide who's leading, who's doing area management, and who's documenting. Have the NRP algorithm visible for reference. For babies at or below 32 weeks gestation, have plastic wrap and a thermal mattress ready. This is frequently tested on the exam. The initial assessment drives your first actions. You'll ask 3 simple questions: term, tone, breathing. So, is the baby term? Does the baby have good tone? Is the baby breathing or crying? If the answer is no to any of these questions, move the infant to a warmer for further evaluation. Position the head in what we call the sniffing position, slight extension of the neck, neutral alignment. Clear the airway if needed, but only use gentle suction. Remember, vigorous or deep suctioning can cause vagal stimulation and bradycardia, so be gentle. Heart rate evaluation is crucial and frequently tested. Auscultation of the heart is preferred over cord palpation. Listen with your stethoscope over the precordium. Your target heart rate should be greater than 100 beats per minute. ECG provides the most accurate assessment, especially during poor perfusion states. When should you use ECG monitoring? During compressions or when perfusion is poor. A key point for the exam: place ECG leads when you anticipate compressions will be needed. Don't wait until you're in the middle of compressions to start placing leads. Assessing respiratory effort is another critical component. Effective breathing should begin within 30 seconds after birth. This timeline is important to know. You need to recognize normal versus abnormal breathing patterns. Primary apnea responds to stimulation. This is where rubbing the back or flicking the soles of the feet might help. Secondary apnea requires positive pressure ventilation. Stimulation alone won't work here. When assessing breathing, look for chest movement and listen for breath sounds. Remember, gasping is not effective breathing and requires intervention. Oxygen management is another frequently tested topic. For term newborns, start with 21% oxygen. That's room air. For preterm babies less than 35 weeks, start with 21 to 30% oxygen. Titrate oxygen based on pulse oximetry readings to maintain saturations in the target range we just discussed. Your goal is to avoid hyperoxia, especially in preterm infants, due to the risk of retinopathy of prematurity and oxygen toxicity. Remember, it's safer to start low and titrate up than to start high and potentially cause damage. The initial steps of resuscitation include thoroughly drying the infant and removing wet linens to prevent heat loss. Stimulate breathing by rubbing the back, trunk, or extremities. Position the airway correctly, slightly extended, midline, with a small towel under the shoulders if needed. Clear the airway as needed, with a bulb syringe being preferred over wall suction. Then evaluate breathing, heart rate, and color to determine your next steps. These initial steps should take about 30 seconds. Be efficient, but thorough. Delayed cord clamping is recommended for 30 to 60 seconds after birth. The benefits include increased blood volume by about 15 to 20%, reduced risk of anemia, decreased intraventricular hemorrhage in premature infants, and improved transitional circulation. Contraindications include maternal hemorrhage and cord avulsion. Recent research has shown that delayed cord clamping doesn't increase the risk of jaundice or polycythemia as once thought, so don't let those concerns stop you from recommending this practice in appropriate situations. Knowing when to start positive pressure ventilation is a critical decision point. Start PPV if you see apnea or gasping respirations, if the heart rate is less than 100 beats per minute despite stimulation, or if there's persistent cyanosis with free-flow oxygen. PPV should start within 60 seconds of birth if needed. This is a critical decision point in the algorithm. The exam frequently tests scenarios where you need to decide whether to start PPV, so be sure you know these indications cold. For positive pressure ventilation technique, deliver at a rate of 40 to 60 breaths per minute. Not too fast, not too slow. Initial pressure should be 20 to 25 centimeters of water for term infants. PEEP should be set at 5 centimeters of water to help maintain lung expansion. Proper mask seal is critical. Use the C technique with your thumb and index finger forming a C on the mask and your remaining fingers lifting the jaw. Deliver consistent rate and pressure. Your target tidal volume is 5 to 8 milliliters per kilogram, just enough to see chest rise. There are 3 main PPV equipment options. The self-inflating bag with reservoir is commonly available, but cannot deliver CPAP or free-flow oxygen. The flow-inflating bag can deliver oxygen and CPAP, any from yourself, but requires more skill to use effectively. The T-piece resuscitator is preferred because it can deliver consistent peak inspiratory pressure and positive end expiratory pressure plus precise oxygen concentration. The T-piece also removes the variability in pressures that can occur with bag devices, especially when providers are fatigued. If ventilation isn't effective, remember the MRSOPA mnemonic for troubleshooting. M stands for mask adjustment. Reposition or reapply the mask for a better seal. R is for repositioning the head with slight extension, midline. S is for suctioning the mouth and nose if secretions are present. O means open the mouth slightly. P indicates gradually increasing pressure if chest rise is inadequate. And A stands for alternative airway, like intubation or laryngeal mask airway, if bag mask ventilation remains ineffective. This troubleshooting sequence is frequently tested. Know it well. How do you know if ventilation is effective? The best indicator is increasing heart rate. This is the gold standard. You should also look for good chest rise with each breath, improved color and tone, and audible breath sounds. Your target is a heart rate greater than 100 beats per minute within 30 seconds of effective PPV. If you're not seeing improvement, go through your MRSOPA steps again. Don't keep doing ineffective ventilation. Troubleshoot and fix the problem. Continuous positive airway pressure, or CPAP, is indicated for spontaneously breathing babies with increased work of breathing. The benefits include stabilizing the chest wall, maintaining functional residual capacity, and improving gas exchange. CPAP requires a proper seal to deliver pressure effectively. Start with a PEEP setting of 5 centimeters of water and adjust as needed. CPAP can be particularly helpful for preterm infants who have poor chest wall stability and surfactant deficiency. Endotracheal intubation has several indications. You'd intubate if bag mask ventilation is ineffective, if prolonged PPV is needed, or in special conditions like diaphragmatic hernia. Intubation is also required for surfactant administration or when tracheal suctioning is needed. A key point for the exam: limit intubation attempts to 30 seconds to avoid prolonged hypoxia. If you can't intubate within that time frame, stop, ventilate with bag and mask to reoxygenate, then try again. Confirming ETT placement is absolutely critical. Misplaced tubes can be disastrous. Look for carbon dioxide detector color change. Yellow indicates carbon dioxide is present, which means the tube is in the trachea. Check for symmetric chest rise and equal breath sounds in both axilla. You should see mist in the tube during exhalation. The heart rate should improve if the tube is correctly placed, and there should be no gastric distension. If you're not sure about placement, it's better to remove the tube and ventilate with bag and mask than to continue with a possibly misplaced tube. There is almost always a question or two about endotracheal tube sizing and depth on the exam. For size, use this weight guide. Less than 1 kilogram, use 2.5 millimeter tube. 1 to 2 kilograms, use 3.0 millimeter. 2 to 3 kilograms, use 3.5 millimeter. For depth, use this formula. For oral intubation, depth in centimeters equals 6 plus weight in kilograms. For nasal intubation, depth in centimeters equals 7 plus weight in kilograms. These formulas give you a starting point, but always confirm placement with clinical signs and carbon dioxide detection. The laryngeal mask airway, or LMA, is used when intubation fails or with facial anomalies that make mask ventilation difficult. There are limitations. Don't use an LMA for babies less than 1.5 kilograms or less than 31 weeks gestation. You cannot give medications through an LMA, and you cannot suction through it either. The advantage is that an LMA is easier to place than an endotracheal tube for less experienced providers. It's a good backup option when you can't intubate but need to secure the airway. Chest compressions are indicated when the heart rate remains less than 60 beats per minute, despite 30 seconds of effective ventilation. When you're compressing the chest, you're manually pumping blood to vital organs, particularly the heart and brain. It's worth noting that chest compressions are actually uncommon in neonatal resuscitation because most babies respond to effective ventilation alone. Here's something critical that's frequently tested. Whenever possible, intubation should be performed before beginning chest compressions. Why? Because ensuring optimal ventilation is absolutely essential. It's the foundation of successful resuscitation. Having an endotracheal tube in place before starting compressions guarantees the most effective ventilation possible. It also prevents the inefficiency of interrupted compressions for mask adjustments. Once compressions begin, immediately increase oxygen to 100% to maximize oxygen delivery during this period of compromised circulation. Remember, effective ventilation is your priority, and securing the airway first sets you up for the best possible outcome. For chest compression technique, the two-thumb method is preferred over the two-finger technique. Position your thumbs on the lower third of the sternum, just below the nipple line. Compress to a depth of 1/3 the anterior-posterior diameter of the chest. The rate should be 90 compressions per minute, using a 3:1 ratio with ventilation, resulting in 120 events per minute total, 90 compressions plus 30 breaths. Keep your thumbs on the chest during pauses to maintain proper position and avoid wasting time repositioning. Coordination between compressions and ventilation is crucial for effectiveness. The compression rhythm should be 1 and 2 and 3 and, followed by breathe for ventilation. The person doing compressions should count out loud to maintain rhythm and coordination. Continue compressions until the heart rate is at least 60 beats per minute. Reassess after 45 to 60 seconds of coordinated compressions and ventilation. If there's no improvement, you'll need to consider medications. Epinephrine is indicated when the heart rate remains less than 60 beats per minute despite ventilation and compressions for 60 seconds. The concentration used is 1 in 10,000, which is 0.1 milligrams per milliliter. For intravenous or intraosseous administration, the dose is 0.1 to 0.3 milligrams per kilogram. with the NRP recommendation being 0.2 milligrams per kilogram. If given through an endotracheal tube, the dose is higher, 0.5 to 1.0 milligrams per kilogram, as absorption is less reliable. Flush with 3 milliliters of normal saline in all infants, even preterm ones. You may repeat the dose every 3 to 5 minutes if needed. Volume expansion is indicated when there's suspected blood loss, poor response to resuscitation, or signs of shock or hypovolemia. The preferred solutions are normal saline or Ringer's lactate. The dose is 10 milliliters per kilogram given over 5 to 10 minutes. You can repeat after assessment if needed. Be cautious with volume expansion in preterm infants due to the risk of intraventricular hemorrhage. O-negative blood is an option when there's known blood loss, as it provides both volume and oxygen carrying capacity. Emergency umbilical venous catheter placement is the preferred route for emergency access. Insert the catheter 2 to 4 centimeters until you get blood return, just enough to get into the vein, not all the way to the heart. Secure it well to prevent dislodgement. Use the UVC for medication administration and volume expansion. The intravenous route is more effective than the endotracheal route for medications, especially epinephrine. Verify the position as soon as possible after the emergency is resolved, ideally with an X-ray. For meconium-stained amniotic fluid, the current recommendation is no routine suctioning. This is a change from older protocols. Only suction if the baby is non-vigorous with an obstructed airway. The initial steps are the same as for clear fluid. Focus on effective ventilation if needed. Intubation for suctioning is only indicated if there's obvious airway obstruction that bulb suctioning cannot clear. This approach has changed over the years, so make sure you know the current recommendations for the exam. Choatal atresia presents with cyclical cyanosis that's relieved by crying. The baby appears pink when crying, but blue when quiet. This is because crying forces airflow through the mouth. Management includes placing an oral airway, considering immediate ENT consultation, and possibly using a temporary oral airway until definitive treatment. Newborns are obligate nasal breathers, so blockage of the nasal passages can cause significant distress despite normal lungs. Tracheoesophageal fistula shows signs like excessive oral secretions and inability to pass an orogastric tube. There's often a history of polyhydramnios, and respiratory distress worsens with feeding attempts. Management includes upright positioning to reduce reflux, frequent suctioning to clear secretions, and avoiding excessive positive pressure ventilation, which can cause gastric distension. The full stomach can compress the lungs and worsen respiratory status, so careful management of ventilation pressure is essential. The APGAR score has 5 components. For heart rate, 0 for absent, 1 for less than 100, 2 for greater than 100. For respiratory effort, 0 for absent, 1 for weak or irregular, 2 for strong cry. For muscle tone, 0 for limp, 1 for some flexion, 2 for active motion. For reflex irritability, 0 for none, 1 for grimace, 2 for cry or cough. For color, 0 for blue or pale, 1 for acrocyanosis, blue extremities with pink core, 2 for completely pink. Memorizing these criteria is high yield for the exam. When interpreting APGAR scores, remember, they're not used to determine resuscitation steps. Don't wait to calculate a score before intervening. APGARs are assessed at 1, 5, and 10 minutes of life. The 1-minute APGAR score primarily reflects the baby's prenatal condition and intrauterine environment, while the 5-minute score reflects the baby's response to resuscitation efforts. A low 5-minute score, less than 3, may indicate a need for cord blood gas analysis. The extended APGAR may be used for preterm infants, continuing assessment beyond 10 minutes. The primary purpose of the APGAR is to document the baby's status and response to resuscitation, not to guide your interventions. When interpreting APGAR scores, remember, they're not used to determine resuscitation steps. Don't wait to calculate a score before intervening. APGARs are assessed at 1, 5, and 10 minutes of life. The 1-minute APGAR score primarily reflects the baby's prenatal condition and intrauterine environment, while the 5-minute score reflects the baby's response to resuscitation efforts. A low 5-minute score, less than 3, may indicate a need for cord blood gas analysis. The extended APGAR may be used for preterm infants, continuing assessment beyond 10 minutes. The primary purpose of the APGAR is to document the baby's status and response to resuscitation, not to guide your interventions. Post-resuscitation care is critical for good outcomes. Monitor vital signs closely, especially temperature, as hypothermia increases mortality and morbidity. Continue respiratory support as needed, whether that's oxygen, CPAP, or mechanical ventilation. Monitor blood glucose. Stress and hypoxia can cause hypoglycemia. Assess for complications like pneumothorax or persistent pulmonary hypertension. Perform a thorough neurological evaluation, especially if there was significant resuscitation. Communicate clearly with the family about what happened and what to expect. Prepare for transport if a higher level of care is needed. When considering transport, assess what level of care the baby needs. Stabilize the baby prior to transport. The baby should be as stable as possible before moving. Pay special attention to thermoregulation during transport, as babies can easily become cold. Continue appropriate respiratory and cardiovascular support throughout. Maintain clear communication between sending and receiving teams about the baby's status and interventions. Remember, transport is a high-risk time, so thorough preparation is essential. Documentation of resuscitation is legally and clinically important. Include a timeline of events, what happened when, document all interventions performed with times noted. Record the baby's response to each intervention. List medications given with times and doses. Include the names and roles of all participants. Document your communication with the family. If transport occurred, include those details as well. Good documentation supports quality improvement and protects you legally. Let's review the key points of the algorithm. Initial assessment drives your intervention decisions. Effective ventilation is your primary focus. Most babies respond to this alone. Heart rate is your main indicator of effective resuscitation. Watch it closely. Follow the clear escalation pathway. Initial steps, then ventilation, then compressions if needed, and finally medications. Always reassess after each intervention to determine if you need to continue, escalate, or can de-escalate care. Debriefing after resuscitation supports quality improvement. Review all resuscitations as a team learning opportunity. Identify whether issues were system-related or due to knowledge or skill gaps. Focus on team performance rather than individual blame. Use video review when available for objective assessment. Document opportunities for improvement and update protocols based on your findings. Regular debriefing improves outcomes for future resuscitations. To summarize the high-yield exam points, master the initial assessment triad: heart rate, breathing, and tone. Know ventilation techniques and troubleshooting steps cold. Memorize oxygen target saturations by minute of life. Be clear on chest compression indications and technique. Know medication dosing, especially for epinephrine. And be able to recognize and manage special scenarios like diaphragmatic hernia and choanal atresia. These areas are most frequently tested on the NNP certification exam, so focus your final review on mastering them. The preferred method for determining heart rate during neonatal resuscitation is direct palpation of the umbilical cord, electronic cardiac monitoring, stethoscope auscultation over the precordium. The correct choice is electronic cardiac monitoring. This question is testing your knowledge of heart rate assessment methods during resuscitation. Electronic cardiac monitoring provides the most accurate assessment, especially during poor perfusion states. Stethoscope auscultation is incorrect because, while better than cord palpation, it's less accurate than ECG monitoring, especially during resuscitation. Direct palpation of the umbilical cord is incorrect because it's the least reliable method and often underestimates the actual heart rate. The target productal oxygen saturation for a 3-minute-old neonate is 60 to 65%, 70 to 75%, 85 to 95%. The correct choice is 70 to 75%. This question is testing your knowledge of target oxygen saturation values by minute of life. 70 to 75% is the target SpO2 range for a 3-minute-old neonate. 60 to 65% is incorrect because this is the target for a 1-minute-old neonate. 85 to 95% is incorrect because this is the target for a 10-minute-old neonate. A full-term newborn is apneic and has a heart rate of 80 beats per minute after drying and stimulation. The next appropriate step is to begin chest compressions, continue stimulation for 30 more seconds, start positive pressure ventilation. The correct choice is start positive pressure ventilation. This question is testing your knowledge of intervention indications based on assessment findings. Positive pressure ventilation is indicated when a newborn has apnea or a heart rate below 100 beats per minute despite stimulation. Beginning chest compressions is incorrect because they're only indicated when the heart rate is below 60 beats per minute despite effective ventilation. Continuing stimulation is incorrect because the baby has already received initial stimulation and now requires ventilation support. After 60 seconds of effective positive pressure ventilation, a newborn's heart rate is 50 beats per minute. The next step should be to administer epinephrine via UVC, begin chest compressions, increase oxygen to 100%. The correct choice is begin chest compressions. This question is testing your knowledge of the resuscitation algorithm progression. Chest compressions are indicated when the heart rate remains below 60 beats per minute despite effective ventilation. Administering epinephrine is incorrect because medication is only given after ventilation and compressions have failed to increase the heart rate above 60. Increasing oxygen to 100% without compressions is incorrect because while oxygen should be increased to 100% when compressions begin, compressions themselves are the necessary intervention. During chest compressions, the correct compression to ventilation ratio is 3:1, 15:2, 30:2. The correct choice is 3:1. This question is testing your knowledge of proper chest compression technique for neonates. The compression to ventilation ratio in neonatal resuscitation is 3:1, delivering 90 compressions and 30 breaths per minute. 15:2 is incorrect because this ratio is used in pediatric resuscitation for healthcare providers. 30:2 is incorrect because this ratio is used in adult resuscitation or single rescuer pediatric resuscitation.